Hello students, good morning. This is Dr. Khushbu Mahajan, your dermatology educator, and today I'll be discussing about important questions which are expected in the NEET PG exam. So before I begin, I'm sure you all are well prepared. So now this month, relax, just revise the important topics and go through these sessions, because here we are trying to cover all the important topics which are expected out of your exam. So before wasting much time, and I would request that if you have any queries, you can post side by side. Once I try to finish with my session, I'll look into your queries and answer them. So coming to the first question from a topic which most likely comes in the exam. So it's a 30-year-old male who presented with flaccid bullae on an erythematous base and had erosions over the oral mucous membrane. The blisters developed painful erosions on rupture. And now the question is not about the diagnosis. The question is, what would be the most likely finding that you would see on immunofluorescent examination of skin biopsy of this patient? So to make this session more interesting, I would request you can post in your answers so that if there is any confusion, I'll try to look at it side by side. So I think most of you know this, so very good. So yes, it is fishnet IgG deposition. So now look at the question like this. So this was a question. The question can be framed differently, but what would you pick out from this question? So the most important clues in this question would be presence of a flaccid bulla, erosions on the oral mucous membranes. And now when you look at this question, you know I'm dealing with immunobullous disorder. In immunobullous disorder, I told you the two important categories that you have to differentiate between are pemphigus group and pemphigoid group. So how do you differentiate between pemphigus and pemphigoid group? The type of bulla, very, very important. So tense bulla or flaccid bulla. So flaccid bulla would be a feature of pemphigus group of disorder, and tense would be in pemphigoid group. Why? Because pemphigoid is subepidermal, so the roof of the bulla is formed by the epidermis, which is a thick structure, and so my bulla would be tense. The second important finding is presence of oral erosions. Now, as I told you, oral erosions are seen in 100% patients of pemphigus vulgaris. And in bullous pemphigoid or pemphigoid group of disorder, they may be there, but are not very common. So if I look at this question, I again get confused that oral mucous membrane involvement can be pemphigus or pemphigoid. But when I look at this flaccid lesion, and then I look at this image, which is showing such flaccid lesions over an erythematous background and where bulla is rupturing, you know that flaccid bulla is seen in pemphigus group of disorder. And so you are clear about that. Now, when we come to pemphigus group of disorder, we have discussed that there are two important categories we need to differentiate: pemphigus vulgaris and pemphigus foliaceus. So how do you differentiate? In vulgaris, there is oral or any mucosal involvement which is not seen in pemphigus foliaceus. This is a very, very important feature. Plus, then what are the type of lesions? In pemphigus foliaceus, you see superficial crusted lesions which are present in the seborrheic areas. So I know this is not relevant for this question, but I'm quickly revising this topic for you because the question may be framed differently and I want you to answer all the questions right. So first, differentiate between pemphigoid and pemphigoid group. Second, differentiate between the two groups of pemphigus, which is vulgaris and foliaceous. Two important things that you will get is oral or mucosal involvement and the type of lesion and where there is present. Another important hint, which is usually given in the question, is presence of Nikolsky sign. So we know that Nikolsky sign is positive in pemphigus group of disorders and absent in pemphigoid group of disorders. So that also helps me differentiate between pemphigus and pemphigoid group. So now coming back to the question, flaccid bulla and oral erosion. So I know that I'm dealing with here pemphigus vulgaris, but they're not asking me the diagnosis. They are saying, what do you see on immunofluorescent examination? Now, this, you know that DIF or direct immunofluorescence is the most diagnostic test. So another important question here. So most diagnostic test is direct immunofluorescence, where I put immunofluorescence and I put antibodies, which I'm expecting. So now when I do DIF, there are 2-3 things that I try to find out. What is it? What is the level of immunofluorescence? Where I am seeing this immunofluorescence, then what is the type of antibody that I am seeing, whether it is IgG or IgA. So when you look at DIF, these are the 3 different patterns that you see most commonly that are asked to you. So in this, what am I seeing? I am seeing a fishnet pattern. A fishnet pattern would mean that my antibodies, which fluorescent labeled, are binding to the keratinocytes in the epidermis, and that is why they're giving a fishnet pattern, which is seen in pemphigus group of disorder. In the pemphigoid group, my antigen is in the basement membrane zone. So what do I see? I see this linear deposition, and this linear deposition I will see in pemphigoid group. Then the third type of DIF is, I see this papillary tip immunofluorescence, which is seen in dermatitis herpetiformis. So now, coming back to the question asked about pemphigus vulgaris. We know we see fishnet pattern in pemphigus vulgaris. So my answer here would be fishnet deposition. Now, what type of antibody? IgG type. So mostly it is IgG antibody, which is there in immunobullous disorder, which will be given to you. But in linear IgA disease, you would get this linear IgA deposition. So this will only be present in linear IgA disease. So if that is the clinical picture, then this will be the answer. Then granular deposits of IgA in dermal papilla, dermatitis herpetiformis, linear IgG in pemphigoid group of disorder. Clear? So based on the question, first identify the diagnosis. Based on your diagnosis, you can mark what type of immunofluorescence do you see. Okay, so I hope this is clear and this topic is clear to you. Moving on to our next question. So a patient presented with 10 to 20, again, I'll mark the important points that you should be looking at in the question. 10 to 20 bilateral asymmetrical erythematous infiltrated plaque shown in the image. Lesions are of varied size and bizarre shape with irregular border and have geographic appearance. So let me see what are the answers that I received. Yes. So here, this is a question on leprosy, very clear from the options or from the presence of infiltrated plaque. Now, when you get a question on leprosy, you have to identify what spectrum they are talking about. So just quickly revising the different spectrum, and then I'll come back to the question. So we know that there are different spectrums. The first is TT. So in TT, what will happen? In TT, I will see lesions which are few in number. which are very, very well defined. So few lesions, so 1 to 10 lesions, if they give you well defined lesion with complete loss of sensation, 100% loss of sensation on very, very well defined lesion would be a lesion of TT. Very dry, complete loss of hair, complete loss of sensation would be TT. Now they give you something which is called as some names that they give to these lesions. So TT lesion is called as saucer right way up. Saucer right way up. So here, well-defined lesion. BT, on the other hand, so as we move down the spectrum, my infection is trying to spread and my immunity is going down. So BT will have typical lesion which has pseudopodia and these satellite lesions. So if you see satellite lesion in the answer, in the question, please mark BT. The number of lesions can be anywhere between 10 to 20, usually will be asymmetrical. This is inverted saucer. So they ask you this. Inverted saucer is seen in BL Hansen. Again, I'll have numerous lesion which will be tending to be symmetrical. Tending to be symmetrical. They are not absolutely symmetrical, but tending to be symmetrical. And I see inverted saucer, and sometimes I see annular or punched out lesion here. Annular or punched out lesion here. Now look at this lesion. This is a typical case of BB Hansen. What was the characteristic of BB Hansen? It is the most unstable form, So here what is happening? My infection is trying to spread like this, giving rise to bizarre shapes or map-like or geographical configurations. So you see any of these terms, you know what answer you have to mark. Inverted saucer, BL. Pseudopodia or satellite lesion, BT. Geographic lesion, bizarre lesion, map-like lesion, BB Hansen. So now let's come back to the question again. So now in the question, even if you don't look at the number of lesions, symmetry or anything, you have this thing. You have presence of geographic appearance. You see this, you can straight away mark BB Hansen. Now, sometimes you may get confused looking at the lesion, that this is a punched out lesion, which is seen in BL. Now remember, BB is an unstable phase. Whatever you see in BL can be seen in BB also. So punched out lesions, annular lesions, Swiss cheese lesions, they all can be seen in BB also and BL also. But presence of this geographic appearance is classical. Here again, look at the lesion. If you still get confused, they are saying asymmetrical lesion. BL lesion would tend towards symmetry. So here the answer would be BB. If BB was not there in the option, then you could have thought of BT or BL, but BL was not given here. So here my only answer that is possible is BB. Okay, so please don't get confused. A lot of time you see this image, you say, oh, it's a punched out lesion. BL is not there in the option. Then what can I mark? Please remember, BB can have all these morphologies, and that is why I gave you this question here. Okay, so that covers the clinical aspect of leprosy. Coming to the next question. 15-year-old girl presented with history of hair loss, which is present since 2 weeks. Just give me a second. Somehow your chat has gone off screen. Okay, so I'm not able to see your chat somehow, so I'll continue with the questions. And by the end of the session, I'll try to log in again and see your questions. So, a 15-year-old girl presented with history of hair loss since last 2 weeks, as shown in the image. The patient is otherwise well. On closer examination of the site, multiple broken hair follicles are seen. So, what are the important pointers in the question here? I have a 15-year-old girl with a history of hair loss, and on closer examination, I see multiple broken hair follicles. So, now look at the image here. Where is the hair loss present? Hair loss is present on a very, very accessible site of my scalp. Now, where do I see this kind of a hair loss? Along with presence of multiple broken hair follicles. I see it in trichotillomania. So when we talk about hair loss or a patchy hair loss, there are different DDs that come to our mind. The first and foremost is alopecia areata. We think that there is a patchy hair loss, it should be alopecia areata. Now, alopecia areata, what sign would you see in alopecia areata? You would see exclamation mark hair. You would see exclamation mark here in a patient of alopecia areata. Then what else can present with patchy hair loss? Something which is called as pseudo-pelade of Brock. Pseudo-pelade of Brock. And this will present with footprints in snow appearance. So footprints in snow is seen in pseudo-pelade of Brock. But what is this? So when you have a young girl, a psychiatric patient, a patient who has some psychological abnormalities, they can have a disorder called as trichotillomania, which is a psychiatric disorder in which, because of anxiety, because of stress, patient without realizing starts to pull out his or her hair. So he or she will do it from the accessible part of the scalp. And when you pull your hair, obviously the cause is outside. You will not be applying an equal pressure. And so my hair would be broken up at different lengths. So hair follicles of different lengths present in an accessible area of the scalp is a straightaway diagnosis of trichotillomania. Like this one, you see a patch of hair loss, but you see lot of hairs, broken hair shaft of various lengths. So in the question, it was quite a straightforward question. They may not have given you this, they may have given you this or some other sign. So you should know that whenever you're dealing with this kind of hair fall, think of trichotillomania, think of that it is a psychiatric disorder. So you have to give that treatment to the patient because they can ask you about treatment also. And on clinical examination, you see hair of various lengths. If it was pseudo-pelade of Brock, you would see footprints in snow appearance. What would be the characteristic of pseudo-pelade of Brock? It would be a cicatricial or scarring alopecia. It would be cicatricial or scarring alopecia. What will be the characteristic of alopecia areata? It would be a smooth bald patch, no broken hair follicles. It is usually a smooth patch which shows exclamation mark here. Whereas there is another type of alopecia that you know, which is called as patterned hair fall or androgenetic alopecia. When present in males, we have Norwood and Hamilton grading. When present in females, we call it Ludwig's type because there is central parting here. So look at this image here. So this is Ludwig's pattern in females, and you see increased widening of the central parting. And by grade 3, this is the pattern that you see, which is called as Christmas tree pattern or fir tree pattern. So Ludwig's pattern of androgenetic alopecia showing miniature hair is seen in female pattern hair loss. So here I had a female, and the important thing in the question was multiple broken hair follicles, which is a part of trichotillomania. And so here the answer would be trichotillomania, showing characteristic hair of various lengths. Okay. The next important topic which is asked is a patient presented with the following lesion. This lesion is characteristic of which disease? So here, what are you seeing? You are seeing these erythematous scaly papules which are present on the interphalangeal joints and on the metacarpophalangeal joints. So what are these? Let me see if I can look at your chat. So this is typically called as Gottron's papules. When you see erythematous scaly papules on the metacarpophalangeal joint or interphalangeal joint, we call it Gottron's papule. And Gottron's papule is a characteristic feature of dermatomyositis. What are the two characteristic features of dermatomyositis? Gottron's papules and Gottron's sign. Gottron's papules and Gottron's sign, and their characteristic feature, if you see them, you can label the patient as dermatomyositis. Why can't it be pustular psoriasis? In pustular psoriasis, even if present on hands and feet, you will see pustular lesions, and they are more commonly located on palms and soles. In guttate psoriasis, you see lesions on trunk. Guttate psoriasis, again, we'll quickly revise because it's frequently asked. You see it in children. You see raindrop-like erythematous scaly lesions, but they are predominantly present on the trunk. They are caused by streptococcal infection, and so there the treatment is antibiotics. What do you see in scleroderma? In scleroderma, you see bound down skin. Okay, so you should be able to identify that this image is of Gottron's papules. If there was just erythema present like this, then it would be called as Gottron's sign, which is also a feature of dermatomyositis. So a lot of time in dermatomyositis, they give you an image and they ask you that what is this seen in? So remember, Gottron's papules and signs are pathognomic for dermatomyositis, but there are other signs also that you see, like you see this V sign on the neck. You see this heliotrope rash. Heliotrope rash is also something which is very commonly asked. You see this heliotrope rash on the eyelids. We have discussed this. This is Gottron's papule. So what is it basically? You see a confluent erythema which looks violaceous in nature. So you see on here, it's sign. You see plaques here. You call it papules. This is V sign. This is heliotrope rash. Sometimes you see it on the thigh when it is called as Holster sign. When you see it on the back, it looks like a shawl, so called as shawl sign. So they ask you shawl sign is seen in. Then sometimes you have mechanics hands. You have hyperkeratosis on the fingertips, which is called as mechanics hand. And then you see these dilated periungual capillaries. So all this can be seen in dermatomyositis. They can give you any of these things and they can ask you that what is it seen in. Most commonly, they give you heliotrope rash, they give you shawl sign, Gottron's papules, and Gottron's sign. So all this is feature of dermatomyositis. Or they can give you a child present with skin lesions and a proximal muscle weakness. Proximal muscle weakness is again a feature of dermatomyositis. Okay. Coming to the next question, identify the phenomena that you see in this image. So what are you seeing here? You are seeing an image where something has been scratched, like this, and along that scratching, you see some erythematous scaly lesions. So this is getting the lesions on the sites of trauma. So on the sites of scratching or trauma, you are getting some lesions. So this is called as Koebner's phenomena, and the other name for Koebner's phenomena is isomorphic phenomena. So sometimes you look at, you know that this is Koebner's phenomena, but you look at the answers and you see there's no Koebner's here. So please remember, Koebner's is also called as isomorphic phenomena, because iso means same and morphic means morphology. So same morphology of lesions. So what is Koebner's phenomena? Whenever a patient scratches or causes a blunt trauma or there is a pinprick, so any kind of trauma, so along the lines of trauma, you have lesions of similar morphology. You have lesions of similar morphology. Then the next question that is asked is, where do you see true Koebner's phenomena? So true Koebner's phenomena is seen in psoriasis, lichen planus, and vitiligo, because they can give you an image like this and ask you, where do you see this phenomena? So true Koebner's is seen in psoriasis, lichen planus, and vitiligo. Sometimes they also ask you, where do you see pseudo Koebner's? Pseudo Koebner's is seen in molluscum and viral warts. In them, it's pseudo because it is because of auto-inoculation or seeding of microorganisms. Okay, so no true Koebner's, no pseudo Koebner's. Let's look at the other signs that have been given to you. What is reverse isomorphic? Reverse isomorphic phenomena is that the lesions improve along the lines of trauma. It is reverse of isomorphic. So here lesions form, their lesions improve. Gottron's papule, we already know it's seen in dermatomyositis. Nikolsky sign, we see in intraepidermal or pemphigus group of disorder. Quickly revising here, where else do you see Nikolsky sign? So Nikolsky sign, apart from pemphigus, which we have already discussed, can be seen in staphylococcal scalded skin syndrome, also called as Ritter's disease. It is also seen in staphylococcal scalded skin syndrome or Ritter's disease, and pseudo-Nikolsky can also be seen in toxic epidermal necrolysis or TEN, a kind of drug reaction. Clear? So you should know about these signs. They are asked, and here we have discussed the common conditions where you see them. Coming to a question from the basics of dermatology, which cell is not present in the shown layer? So here you need to know two things. On histopathology, which layer is where? So first, you should be able to identify that what layer of skin am I pointing to here. So we should know that there is stratum corneum, stratum granulosum, stratum spinosum, and stratum basale. So I am pointing to stratum basale. Come, let's get sunburnt is a mnemonic to remember the layers of the epidermis. So SC, stratum corneum, is stratum granulosum, stratum spinosum, and basale. Please know these layers. Sometimes they ask you about the layers of the epidermis. Now here I'm pointing to the stratum basale and I'm asking you which cell is not seen here. So remember, in epidermis, we have 4 types of cells. The most predominant is my keratinocyte, which is almost 95%. And then there are 3 cells, which are Merkel, melanocytes, and Langerhans cells. So in basal layer, I have melanocyte. You all know that in basal layer, only these dendritic melanocytes are present, which give pigment. So that is there. Keratinocyte is present in all layers of the skin. Keratinocyte is present in all layers of the skin. We are left with Merkel cells and Langerhans cells. So Merkel cells are touch receptors, which are also present in stratum basale. So the answer here would be Langerhans cells, because they are present in stratum spinosum. You should be knowing this. So Langerhans cells are present in stratum spinosum. Merkel cells and melanocytes are present in stratum basale, and keratinocytes are present on all layers of the skin. Okay, so here I will quickly revise the important points that you should be knowing about all these cells. So keratinocytes present in all layers. More than 95% of my cells are keratinocytes. Where is it derived from? It is derived from ectoderm. It is derived from ectoderm. Langerhans cells are seen in stratum spinosum. They are dendritic cells. They are also dendritic cells like melanocytes. Their role is they act as antigen presenting cells. They act as antigen presenting cells, and they have a particular granule called as Burbeck granules in them. They have granules called as Burbeck granules in them. Coming to my next cell, which is my melanocyte. Now, this Langerhans cells is derived from mesenchyme. Then comes my melanocyte. My melanocyte is the pigment forming cell. It is my pigment forming cell which is present in stratum basale, It is derived from neural crest and it is present in the ratio of 1:10. So for every 10 basal cells, I have one melanocyte. This is also a dendritic cell. Then you should know what is epithelial, EMU or epidermis melanin unit. So that is 1:36, which is one melanocyte transfers its melanin to 36 keratinocytes. Clear? So these are all important points about these cells. Then coming to Merkel cell. Merkel cell is a slow adapting touch receptor. Slow adapting touch receptor, which is again present in the stratum basale. Okay. So don't get confused. These are the 4 cells that are present in the epidermis. You should know that Langerhans cells is in stratum spinosum, keratinocytes in all layer, and these 2 cells, which is melanocyte and Merkel cell, both MM, are present in stratum basale. And you should know these basic features about all these cells. Okay. Coming to the next question. A man is having multiple painful non-indurated undermined ulcer with sloughed edges over glands, which occurred 5 days after sexual exposure. What is the most likely finding? So here again, they're not asking me the diagnosis. So here we'll quickly revise your genital ulcer disease based on which you should be able to answer this question. So first, let's look at the various hints given to us. Multiple, painful. Multiple and painful, when they say, we think of 2 main conditions, HSV and chancroid. Because we know our syphilis is painless, donovanosis and LGV do not present with multiple painful non-indurated lesion. But then how do I differentiate between HSV and chancroid? Based on the edges that they have given you. Undermined and sloughed edges. Undermined and sloughed edges is typical of chancroid. Rest everything, multiple, painful, non-indurated, occurring incubation period of 5 days can be seen with HSV or chancroid, but chancroid has undermined ulcer with sloughed edges. So let's look at the different ulcers and quickly revise it, and then we'll come back to the question. So what is this? What do I see here? I see multiple painful non-indurated lesions which have sloughed edges. This is typical of chancroid. Chancroid. Multiple painful non-indurated means soft. Non-indurated with undermined sloughed edges. So here again, where do you see undermined edges in dermatology? You see it in chancroid, you see it with TB chancre, and you see it with pyoderma gangrenosum. So 3 conditions. So undermined, you see, you think of these 3 conditions. Then sometimes they give you an image. What do you see here? You see Haemophilus ducreyi, which is the causative organism, which forms railroad track or fish and stream appearance, as if they are going together. So railroad track appearance is seen in chancroid. These are H. ducreyi, which you are seeing, which are arranged in pairs or in groups, and they appear as single line. Okay. Then what is this? This is a typical image of a chancre. Chancre is caused by Treponema pallidum, syphilis, primary stage. What do I see? I see a single lesion which is painless, which is indurated, which has a rubbery consistency. Anything can be given to you in the exam. But the important point here would be single, painless and indurated. What test will you do? T pallidum, we know we do dark ground microscopy. And what do you see? You see these slender, wavy, fluorescent organisms here. So this is chancre, single, indurated, painless ulcer showing positive dark ground microscopy. What is this? What is this? Here you are seeing multiple coalescing vesicles. Multiple coalescing vesicles and erosions. You do not usually see an ulcer here. You see multiple coalescing vesicles and erosion which are painful. Which are painful. They do not have sloughed undermined edges. So painful lesions which are multiple coalescing. What do you do? This is caused by herpes simplex virus, which is a virus. So you will do a Zang smear here. Sometimes they ask you this, they give you an image, what test would you perform? So you should know all about it. So Zang smear, where you see multinucleate giant cells along with acantholytic cells. Okay, so multinucleate giant cells with acantholytic cells with multiple coalescing vesicles and erosions. What is this? This is donovanosis. How do I identify this? Donovanosis has a long incubation period. Syphilis has a long incubation period, 10 to 90 days. HSV, chancroid, short incubation period, 5 days, 7 days. Donovanosis, long incubation period. What do you see? You see beefy granulomatous ulcer. Beefy granulomatous ulcer, which is usually again painless, So painful lesions are two, chancroid and HSV. So you see this is usually single, it appears beefy and granulomatous. Okay, and this is caused by Chalaemetobacterium granulomatous, and this shows safety pin appearance. So safety pin appearance is seen with donovanosis. What do you see in LGV? In LGV, you hardly see any ulcer. You do not see any ulcer. What you see is predominantly lymphadenopathy, and which is present in the inguinal or femoral node. And what do they ask you in this? This is a sign of groove. So in LGV, which is caused by chlamydia, you see groove sign because both my femoral and inguinal lymph nodes are involved. So Popot's ligament in between them gets taut, giving rise to sign of groove. So this is typical of LGV. Genital ulcers are very commonly asked. So we quickly revised. You can be given any of this image. You can be given any of the investigation related to this. So coming back to the question here. So I have a man with multiple painful, non-indurated, undermined ulcer with sloughed edges. So undermined, you see, you think of chancroid. What do you see in chancroid? You see on gram stain, you see a railroad track appearance or school of fish appearance. So here the answer would be this. Spiral organisms on dark ground, we know syphilis. Multinucleate giant cells on Zang smear, we know herpes genitalis. And groove sign you will see in LGV. Again, a very, very important topic. Okay, so if you know these differences, you will be able to crack it very well. Okay, a 26-year-old male came to the OPD with a belly button rash. You can see a belly button and you see a rash along the belly button. It's slightly itchy and uncomfortable. What is the potential agent for the same? So there is a belly button, there is a rash. I know I'm dealing with contact allergic dermatitis. And I told you in contact allergic dermatitis, you know that what is important for you, that what is causing it and what is the causative allergen. So you should know about some of the common allergens. What is the most common metal allergen which causes contact allergic dermatitis? It is nickel. So in belly buttons, in artificial jewelries, in your belts, the buckle of the belt, what metal is present? You should know it is nickel. So it is nickel allergy that is being shown here. Okay. So then where do you see PPD? So let's revise this table quickly because you can get any of these allergens here. So artificial jewelry, jean buttons, the buckle of the belt buttons, they all have nickel and sometimes cobalt, but you just remember nickel. Where is chromium present? Chromium is present in cement, painting. Potassium dichromate is present in leather. It is present in detergent. So painters, even cement workers can have potassium dichromate. Okay. Plants have parthenium. We have read about parthenium dermatitis. So plants have parthenium. Hair dyes have paraphenylene diamine or PPD. So they can give you an image of a female hair dyed and can show an allergy there and ask you what is the allergen there. So it is PPD, which is seen in hair dyes. Then they sometimes give you an image of a female who has a allergic dermatitis on the forehead hair. This is nothing but bindi dermatitis. And what is the allergen there? Para-tertiary butyl phenol. Para-tertiary butyl phenol. Most common topical agent or topical medicine which causes contact allergic dermatitis, it is neomycin. Please remember these important allergens and their sources because that is how they give you the question in the exam. Okay. All right. A 12-year-old male who is a kidney transplant recipient presents with multiple brown papules on the forehead and scalp. Which of the following is the common cause? So when you look at the options, you don't have to think of what it is. It is HPV, so they're talking about warts. But just in case it was not given and you were asked to diagnose, so here you see these keratotic papules which are flat-topped. So this is verruca plana or plain warts. Verruca plana or plain warts. Now, I told you plain warts are more commonly seen in immunocompromised individuals. So in the history, in the question, they are making it clear to you that it's a kidney transplant recipient. It's a kidney transplant recipient, so immunocompromised. So the another point of this is sometimes you look at the image and you're not sure whether it is verruca plana, verruca vulgaris, or what type it is. So remember on face, when you see and you see more of flat top lesion, and in the history, there is some history of immunocompromised stage, they are talking about verruca plana. So that's clear. Then I told you they ask you about HPV subtypes. So what subtype causes verruca plana? It is HPV 3 and 10. How do we remember? With the help of a mnemonic that we did, which is DSP, come eat a burger. So DSP, come eat a burger, which is deep plantar wart, superficial plantar wart, plain warts, common warts, EDV, anogenital warts, and butcher warts. So even if you have not remembered till now, let's do it right now. DSP, come eat a burger. So just write this and then start writing the counting. So this is what these are caused by. They very commonly ask you the HPV subtype. So you should know 1, 2, 7. Then there are some other 3s also 10. And then in EDV, you should know 8, here 6, 11, 16, 18. So these all you should be knowing about. But just remember 1 to 7 and you will be able to mark. Even if you didn't know 10, you know HPV subtype 3. DSP, plain wart, is caused by HPV subtype 3. So here you should be able to first identify the condition and then tell what HPV subtype it is. So 6 and 11 is anogenital wart. So they would have given you an anogenital area. HPV subtype 2 is superficial plantar wart. So they would have given you a feet. HPV subtype 16, 18 is also anogenital wart, which is a high risk anogenital wart. So here again, an important point, this is low risk and 16, 18 is high risk type of anogenital wart. By high risk, I mean they are predisposed to, they are precancerous in nature. So if they have given you Buschke-Lowenstein tumor, which is giant condyloma acuminata, then it would be HPV subtype 16 and 18 because it is caused by high-risk HPV types. Clear? Okay. The test shown in the image is an example of, so what is this test shown? You can see the back of a patient, you can see some patches, you can see some markings. This is a classical example of a patch test. Quickly revising patch test. So patch test is done to identify what allergens are causing contact allergic dermatitis. So here what is happening, I am utilizing that there is a sensitization phase which has happened, and now by applying the patch test, I am eliciting that immune response. So what kind of hypersensitivity it is? There are memory T cells which are acting here. So this is a type 4 hypersensitivity. So patch test, please remember, is a type 4 hypersensitivity. It helps me identify allergens in contact allergic dermatitis. What is the site of patch test? It is back. When do I take the reading? I take two readings, one at 48 hours and the other at 96 hours. So if they ask you this question that when is the reading taken for patch test, it is 48 hours and 96 hours. However, if two options are not there and they give you 48, 96, 24, 12, whatever hours, so then what will you mark? If both are there in the option and they are not together, then please mark 96 hours, because at 96 hours, we can see the delayed reactors also. If this is there, this will be my best answer. If this is not there, then this answer. If this is not there, then my third answer would be 48 hours. So we see it after this, and then we identify the allergen. So these are some important questions that they are asked about patch test. Sometimes they ask you, what is photo patch test? In photo patch test, you put these patch tests in duplicate, and then at 48 hours, you irradiate with UVA light, and then you examine and see that what side shows allergies. So photo patch test, both are important. They are type 4 hypersensitivity reaction. Next question. A child known case of asthma is well controlled on medicines. He came to the OPD and physician noted an important clinical sign in this patient. What is the sign? So a child is a known case of asthma, well controlled in the medicine. So if the question is referring to asthma in dermatology, they are talking about this atopic triad. They're talking about this atopic triad where a patient can have atopic dermatitis, asthma, or hay fever, or any of these. So it is pointing towards a possibility of atopic dermatitis in the patient. It is pointing towards possibility of atopic dermatitis in the patient. But in the question, they are asking you an important clinical sign that you see. So what important clinical sign are you seeing? You are seeing this extra fold of lower eyelid skin. An extra fold of lower eyelid skin, which is also called as Denny-Morgan fold and is a feature of atopic dermatitis. So you are seeing Denny-Morgan fold here. So in atopic dermatitis, again, there are a lot of questions. You should know about atopic triad. They can give you a flexure and say the patient presents with constant itching. So in atopic dermatitis, itching or pruritus is a feature which will always be present. In the childhood phase, in the adolescent phase, we see a lot of flexures involvement. So a lot of time they will give you a cubital or popliteal fossa and give you eczematous lesions over there. Then they will give you whether there is a self-history or a family history of asthma or something like that. So all this will point towards atopic dermatitis. Then sometimes they give you something they give you this clinical scenario and they ask you what type of immune responses is there. So here I have Th2 type of immune response. So there will be increased IL-4 and 13 and increased IgE. And there is increased transepidermal water loss. So all this has been asked regarding atopic dermatitis in the past. So Th2 response, high IgE, high IL-4, 13, increased transepidermal water loss. So all this can happen. Then what can you see? You can see Denny Morgan's fold. Then in the options, they had given you Hertog sign. What is Hertog sign? Loss of lateral third of the eyebrows. Loss of lateral third of the eyebrows is Hertog sign. This is Denny Morgan fold, which is the most characteristic finding that you see. Then you can see papillary conjunctivitis, keratoconus, anterior capsular cataract. Then they had given you headlight sign. What is headlight sign? It is seen in the perioral area where there is cheilitis, which forms one light. Then there is a perioral pallor and there is inflammation surrounding it. So that is headlight sign. So headlight sign is also seen in atopic dermatitis, but it is around the mouth. Hertog sign is loss of eyebrows, and keratoconus is also something that you see, but in this image, you're seeing Denny Morgan's fold. You're seeing Denny Morgan's fold. Other signs that you may see, you can see keratosis pilaris, palmoplantar hyperlinearity, ichthyosis, and something which we call at white dermographism. These are all minor features of atopic dermatitis, and you can be given any of these. Next question. A 20-year-old female complains that in previous 3 to 4 years, all her toenails have changed color. The rate of nail growth has also slowed enormously. There are no other complaints. What treatment should be recommended for the most likely diagnosis? So now when you look at this image, there are two things that come to your mind, I'm sure. One is onychomycosis and one is psoriatic nail. How do I differentiate? Now, usually when they will give you psoriatic nail, they will either give you more of, so psoriatic nails involves more of fingernails, whereas onychomycosis involves more of toenails. Okay, usually psoriatic nails involves multiple nails, and this involves usually few, but can involve all 20 nails also. The third important thing, here you will see pits. Here you will not see pits. Here KOH will be positive and here KOH will be negative. So any of this can be given to help you identify whether it is onychomycosis or a psoriatic nail. But here what have they given you? Just a discoloration which is present, which has slowed the nail growth and no other findings present. But look at the nail here. There are no pits that you see. There is no oil drop sign. So you can say, and they have given you a toenail. So toenail, no pits, no oil drop sign. You can safely assume that they have given you a case of onychomycosis. Now coming to, but they're not asking you the diagnosis again. They're asking you what treatment would you recommend here. So will you give mild steroids? Obviously not. Will you give topical terbinafine? But I told you, you usually do not use topical treatment, especially if there are multiple toenails involved. If it was a single toenail, then you can think of topicals. And in that case also, you would prefer topical nail lacquers like cycloperoxolamine or emerolfin nail lacquers. You will not give topical terbinafine, which is not available as nail lacquer. Now we are left with the other two options, oral terbinafine. Now, oral terbinafine for 6 weeks or for 3 months. So remember, in fingernails, you give it for 6 weeks, and in toenails, you give it for 12 weeks. So here the answer would be oral terbinafine for 3 months or 12 weeks. You should also know that what are the other options for treatment. So you can give oral itraconazole also, which is given usually in the pulse form. What is that? 200 milligram twice daily for 1 week every month. Because that may be also there in the option. So pulse itraconazole therapy, which is 200 milligram BD 1 week per month. You give 2 to 3 cycles for fingernails and you give 4 to 5 cycles for toenails. Right? So terbinafine, itraconazole oral is the option, is the treatment of choice for onychomycosis, especially if it involves multiple nails. If it is a single nail, you can give nail lacquer, and those are emerolfin and cycloperoxolamine. Quickly revising, what are the different types of onychomycosis? Distal lateral subungual onychomycosis, proximal subungual onychomycosis seen in HIV patients, superficial white onychomycosis, and total dystrophic onychomycosis. But that does not change the treatment. In most of these, we give oral treatment. In superficial white, you can give topical treatment. Coming to the next question, tuberculids are type of cutaneous TB. Which of the statement is incorrect for the same? So tuberculids, we have read about cutaneous tuberculosis. They can be endogenous, exogenous, or tuberculids. What are tuberculids? Tuberculids are hypersensitivity reaction. They are hypersensitivity reaction to Mycobacterium tuberculosis or one of its antigens. So in this, what happens? Usually, there is a primary focus of TB elsewhere from where the MTB is released, or some remnants are released, to which my body mounts a CMI response or cell-mediated immunity. And when that mounts it, it leads to development of skin lesions. So these skin lesions are because of CMI, not per se due to bacilli. So if I do AFP, it will be negative. If I will do a culture, it will be negative. But if I do a histopathology, I will see a tuberculoid pathology here. And how will I treat it? I will treat tuberculosis only. And when I do that, when I treat TB, I treat the focus of TB, the CMI goes off and tuberculids improve. So yes, they respond positively to ATT. Yes, there is a focus of infection of TB somewhere. You cannot culture AFP because it's a hypersensitivity reaction. But here the CMI is high, and that is why hypersensitivity reaction is occurring. So this is incorrect. There is CMI, and so if you do a Montus, it will be positive. Okay, so tuberculids are again an important topic. So you should know that here the CMI is high. Sometimes they give you image and ask you about various kinds of tuberculoids. So three main tuberculoids that you should be knowing. So first is lichen scrofulosaurum, which is a micropapular tuberculid. You see micropapular, perifollicular, lichenoid lesions. Micropapular, perifollicular, lichenoid lesions, which are present in groups. They are present on trunk, usually in children. Asymptomatic. These are all asymptomatic lesions. So you micropapular lichenoid lesions present in groups. You do a biopsy, you see superficial perifollicular dermal granulomas. The next type is called as papulonecrotic tuberculid, where you see it in adults. And where do you see? You see it in extremities. And you see necrotic papules. You see necrotic papules. The third type is the nodular type, which is called as erythema induratum of Bazin. Where do I see this? I see this in females which are middle-aged. Where do they present on? Posterior calves, and they heal with scarring. So all these three tuberculids, you should know the basic points and you should know what are tuberculids. So you see this nodules on the posterior calves, they heal with scarring. This is nodular tuberculid. Okay, the next question. A farmer from UP came to OPD with ulcerating nodules on hand with pus discharge from the same. So I have an ulcerating nodule. It is slowly progressing and worsening. On examination, I see regional lymphadenopathy. The doctor ordered histopathological examination with below finding. So what do you see in the image? You see these nodules which are present in a linear distribution, which is also called as porotrichoid pattern. And what do you see on histopath here? You see an eosinophilic body with some radiating eosinophilic material called as asteroid body. Called as asteroid body. Now, where do you see all of this? You see it in sporotrichosis. So important pointers, there is a farmer, presence of linear lesions in sporotrichoid pattern, presence of lymphadenopathy. That means there is lymphatic spread, and presence of asteroid bodies on histopathology. So it is a type of subcutaneous mycosis or subcutaneous fungal infection, usually seen in rose gardeners, caused by Sporothrix skenkai. Sporothrix skenkai. And the typical feature would always be presence of ulcerating nodules in the lymphatic distribution or linear distribution. And if you do a histopathology, you see asteroid bodies. If you do a PAS stain, you see cigar-shaped bodies. Sarcoidosis never ulcerates. Fish tank granuloma is an atypical mycobacterial infection where they will give you some history of contaminated swimming pool, contaminated water. Usually it is a single lesion, does not present in linear fashion. Leishmaniasis, you would get, again, you will not get these linear lesions, and there will be central crusting in the lesion that will be given to you, and they will give you some endemic area. Asteroid bodies are not seen in any of these, right? So you should be able to identify this. A 50-year-old male presents with solitary ulcer over face. They have asked you a question on this a lot of times. On examination, you see a solitary ulcer with beaded margin. Solitary ulcer with beaded margin and telangiectasias over right cheek. What is the diagnosis? Very, very clear-cut picture. They usually give you an image question on this. So when you see an ulcerated lesion present just below the eye, on the cheeks, and there is beaded margin with telangiectasias, please think of basal cell carcinoma. Basal cell carcinoma is the most common cutaneous malignancy. It usually present above this line. If you join the line from the ale of the nose to the tragus, above this line, just below the eyelid, sometimes they give you a lesion on the nose. But the characteristic thing is there is an ulcerated lesion and the margins are raised, overhanging, or beaded, and they have telangiectasias. This is also referred to as rodent ulcer. Rodent ulcer. This is nothing but basal cell carcinoma. Basal cell carcinoma. This is how my SCC looks like. It can present in varying morphology. There is no characteristic feature per se, except that beneath the ulcer, you see a little induration. SCC is seen in white skin, exposed parts of the body, and there is induration, but there is no beaded margins, no telangiectasias. This is how a keratoacanthoma looks like. There is an outgrowth with a central material which is extruding out. So there's a dome-shaped lesion with central extruding material. A malignant melanoma looks something like that. A pigmented lesions showing varying pattern of color, varying surface. You have heard of A, B, C, D, E, asymmetry, border, color, diameter, or evolution. Something may be different. But BCC is very, very characteristic, and it is the most common cancer that you see. So that was all about the important questions and important topics which we can expect in your NEET PG exam. I'm sure there must be a lot more, but I tried to cover whatever is possible in this 1 hour. And I wish you all the best, and I hope you come out of it with flying colors. Don't worry, don't get confused. If you have any queries, feel free to post to us, but just relax and study, and you'll be able to crack your exam. I am still not able to get your chats. So I'll just try that once before leaving the meeting, so that if you have any queries, I can answer that.